All right, today we're playing medical detective. We're going to be investigating a condition that is a true master of disguise. I'm talking it can look like liver disease, a movement disorder, or even a psychiatric illness. We are cracking the case on Wilson's disease.
So let's start with a patient. Picture this, a 25-year-old walks in. Their liver enzymes are up, they feel a little depressed, and they've started feeling clumsy. Okay, so your mind is racing, right? Building that differential. You're thinking, could it be autoimmune hepatitis, a weird drug reaction? Maybe it's just a primary psych issue with some unrelated liver stuff. But there is one diagnosis you absolutely cannot afford to miss here.
And that diagnosis is, you guessed it, Wilson's disease. There's a reason we call it the Great Masquerader. It's because of cases exactly like this one. It can mimic so many other, more common things, which is why your most powerful tool isn't a lab test or a scan, it's a high index of suspicion. You've got to think of it to find it.
So to understand how this great masquerader pulls off its act, we need to get into its motive and mechanism. And really, it all boils down to one simple but devastating problem: too much copper.
So here's the formal definition. Wilson's is an autosomal recessive disorder. You know what that means? You get one faulty copy of a gene from each parent. And the gene in question, the main culprit, is called ATP7B. Its whole job is to help the liver get rid of extra copper. When that gene is broken, the copper has nowhere to go, and it just builds up and up to toxic levels.
Let's walk through how this happens, step by step. So, we all eat copper in our diet. It gets absorbed. That's step 1. Totally normal. Step 2, that copper heads to the liver to get processed. Still all good. But step 3, this is where everything goes sideways. That ATP7B protein, think of it like a bouncer at a club whose job is to kick out extra copper. In Wilson's disease, that bouncer is asleep, so copper just keeps piling up inside the liver. Eventually, the liver can't hold any more, and that's step 4. It spills out into the blood and starts causing chaos wherever it lands, especially in the brain and the eyes.
And because that copper can literally go anywhere, the clinical clues are all over the place. This is not a disease with one neat, tidy presentation. It has so many different faces, which, you can imagine, makes finding those clues a huge challenge.
And this table right here really drives that point home. I mean, look at this spectrum. On the liver side, it could be anything from just mildly elevated enzymes you find by accident, all the way to fulminant liver failure. Neurologically, it can look just like Parkinson's disease. Psychiatrically, a patient could carry a diagnosis of bipolar disorder for years before someone figures it out. This disease just does not stay in its lane.
Now here's a really high-yield clinical pearl for you. If you're going to remember one thing, make it this. Of all the neurologic signs, the single most common one you'll see when a patient first presents is dysarthria. That's slurred or difficult speech. It is a massive clue.
And let's just go ahead and bust a common myth right now. A lot of us think of Wilson's as a disease of kids and young adults, but the guidelines are crystal clear. You cannot and should not rule it out based on age. Seriously, there are cases of people getting diagnosed for the first time in their 70s, even their 80s.
Okay, so you suspect it, you've got it on your differential. How do you actually prove it? Let's open up the diagnostic toolkit and see how we gather the evidence.
This is your first-line set of tests, your opening move. Of course, you'll get the basics: liver function tests, a CBC, INR. But the 3 really key tests, the ones specific for Wilson's, are the serum ceruloplasmin, a 24-hour collection for urinary copper, and a slit lamp exam by an ophthalmologist to hunt for those Kayser-Fleischer rings.
Now, let's talk about a huge diagnostic pitfall: ceruloplasmin. It's the main protein that carries copper in the blood. And yeah, in Wilson's it's usually low, but, and this is a really big but, a normal level does not rule it out. In fact, it can be normal in up to half of patients who present with liver disease. So if it's low, that's a great clue. If it's normal, it means nothing. You've got to keep digging.
The other really key initial test is that 24-hour urine copper. And the magic number to remember for a symptomatic patient is greater than 100 micrograms. It just makes sense, right? The liver is so overloaded with copper that it's just spilling out into the blood, and the kidneys are trying their best to get rid of it.
So what happens when the case is murky? The ceruloplasmin's kind of borderline, the urine copper isn't definitively over 100, and there are no KF rings. What do you do then? Well, that's when you have to call in the heavy hitters, like a liver biopsy to directly measure the copper content, or moving on to genetic testing.
And this brings us to how we put all the pieces of this puzzle together. To handle a disease this variable, researchers came up with a scoring system to weigh all the evidence, and that's what the Leipzig score is all about.
This is how you crack the case. The Leipzig score is basically a point system for all the clues we've been talking about. If you find those pathogenic mutations on both alleles, that's 4 points right there. Game over, you've got your diagnosis. But let's look at how the other clues add up. Go back to our first patient. They had neuro and psych symptoms. That's 2 points. Let's say their urine copper comes back at more than twice the upper limit of normal. That's another 2 points. And boom, 2 plus 2 is 4. A score of 4 or more means the diagnosis is highly likely. It's such a powerful tool for synthesizing all the data.
So we've solved the mystery. We've made the diagnosis. But our work is definitely not done. The resolution here means lifelong management to make sure the copper never builds up again.
And these are the 3 main tools in our treatment toolbox. You have chelators, like deepen and trientine, which basically grab onto copper and help you pee it out. Trientine is generally the favorite these days because it's tolerated a lot better. Then you have zinc, which works in a completely different way. It blocks you from absorbing copper in your gut in the first place. This makes it a great choice for long-term maintenance therapy once you've gotten the initial copper load down.
And this is so important to remember. Management is a marathon, not a sprint. This therapy is for life. You've got to monitor these patients closely, checking their liver function, their blood counts. You have to check their urine copper every year to make sure the treatment's working. And, just as importantly, that they're taking it, because the stakes couldn't be higher. If they stop their treatment, it can lead to fatal liver failure.
And one last thing, your job isn't done with just your patient. Because this is a genetic disease, it is absolutely critical to screen all first-degree relatives. We're talking parents, siblings, children. Just think about that. You could find an asymptomatic family member, start them on treatment, and prevent them from ever getting sick. That is a massive, life-saving intervention.
Okay, we've covered a ton of ground, so let's boil it all down. What's the one message you need to take with you into your practice?
It's really this simple. Think Wilson's. Just keep it in the back of your mind. Anytime you have a patient, especially a younger one, with some unexplained mix of liver problems, neurologic symptoms, or psychiatric issues, just let that little alarm bell for Wilson's go off in your head. Because this is a treatable disease, and being the detective who cracks the case early will completely change your patient's life.
And I'll leave you with this final thought to chew on. The number of cases we actually diagnose is about 1 in 30,000 people. But genetic studies suggest that the number of people who actually have the 2 faulty genes could be way higher, maybe as high as 1 in 7,000. That's a huge gap. It really makes you wonder, right? How many of these great masqueraders are still out there, just waiting for someone to make the diagnosis?